So without further ado, I would like to now introduce our next speaker, Dr. Marcus Butler, MD. Dr. Butler is a physician investigator with an interest in translational development of immune-based therapies of cancer patients. He joined the Department of Medical Oncology and Hematology at Princess Margaret Cancer Centre in 2012 and is an assistant professor at the University of Toronto. He cares for patients with melanoma and is the director of Princess Margaret Immune Monitoring Laboratory. His work focuses on the development of immunotherapy trials, which includes studies alone in combination with immune checkpoint blocking antibodies and immune modulators and adoptive cell transfer. Welcome, Dr. Butler.
Thanks very much for the opportunity to speak today. So I'm going to talk a little bit about what happens if you develop metastatic melanoma. We do have, there are therapies that are coming down the pike for adjuvant therapy. That's when you have high-risk disease and then you receive a treatment. Nothing has yet been approved for adjuvant therapy by Health Canada, but we do have trials that are we're waiting on the results for, and there are trials that are ongoing now to try to look at those treatment options. So not yet, but soon we're going to be done with interferon, I suspect, so that we'll have other options. These are, I have a few disclosures where I serve on advisory boards for pharmaceutical companies. So the melanoma statistics are that around 5,000 patients are diagnosed with melanoma per year, and about 1,000 patients a year in the recent past were passing away from the diagnosis. However, we are seeing a shift in these numbers where more and more people are living longer, not dying of their disease. And we're hoping that these numbers we'll start seeing improvement in these numbers in the coming years. The overall risk of developing a melanoma, however, as was mentioned at the beginning, is going up. And that's mainly because of exposure to ultraviolet radiation, so that we now have about a 1 in 50 chance of Canadians developing melanoma at some point in their lifetime. So it's a combination of people living longer, and then also in the mid-20th century, people weren't really aware of the fact that ultraviolet light was damaging to the skin and could cause an increased risk. When I go to meetings and we have conversations with our colleagues from Australia, they're shocked that we have tanning beds that you can still use in North America, because in Australia they've totally gotten rid of tanning beds, for instance, because those things really do increase the risk, and a lot of times young people don't really recognize that there's a risk associated with tanning. So one of the first things that really changed our treatment of melanoma is the development of targeted therapies. About 40% of patients with melanoma will have a mutation in the BRAF gene. The way to understand what these targeted agents, what they're doing, is they're targeting a mutation to try to turn off the signal that the melanoma cell has that is telling the cell to grow and divide and persist. So in cancer, the way the nucleus, which is kind of the brain of the cell that understands that sort of tells the cell to divide, the way that it gets signals from outside of the cell is there are these molecules that form a kind of, you tell a friend and it's sort of a phone call tag team that goes down the process to the nucleus through these different molecules. And in cancer and in melanoma, often there are mutations in the BRAF gene. There are other types of mutations that melanoma patients have in the NRAS gene or other genes involved in the pathway, Whereas in normal cells, the only way that you can send this signal is through interactions of growth factors with receptors that then cause a signal to go down to the nucleus. So in cancer, there's a mutation, and it's basically like the light is left on and the signal persists and tells the cell to go. And the way that this can also be understood is that the cancer cell is always turned on. The engine of the cancer cell is revved up and ready to go, whereas normal cells are more easily controlled and respond to various signals. So when about 10 years ago, BRAF mutations were identified and drugs were used to target these BRAF genes, we saw some incredible responses where the drug can target the abnormal BRAF mutation and allows the cell to go back to normal function because this signal is inhibited and the cell responds to normal signals. And in the early studies, patients either received this targeted therapy. The first drug to be studied was vemurafenib, or chemotherapy, a drug called dacarbazine, and we saw a significant improvement in survival. So the way to understand these survival curves is that on the y-axis, when you start, 100% of the people are alive, and then as time goes forward, some people pass away, and then if 90% of the people are alive, then you see the curve is represented here, and that's about 5 months, for instance. And when you compare the survival curves for vemurafenib versus dacarbazine or chemotherapy, we see the targeted therapy, patients live much longer than patients who receive chemotherapy. And the very disappointing thing about this drug, it was extremely exciting for us when we started giving this drug, because we could have patients who really were literally very, very sick from their disease and had very little hope. Life expectancy measured in months, could take this pill and then start feeling better again, much, much, much better. Unfortunately, we found that many of these patients who had large volume disease would have an improvement in their symptoms, but then would begin to have problems again, and their disease would start to grow again. And that's why we have this what's called a banana curve, where you have improvement in survival for the patients that get the effective drug, but eventually towards the end of the curves come back together again, because even though you got the treatment, the disease eventually develops resistance and patients have progression. And so you'll see median survival where patients are living longer. Doesn't necessarily mean that the median, only one person gets to be the median. So each individual is unique. Some people will get more benefit than others. But in general, what these curves mean is that as a population, the patients who got vemurafenib did better than chemotherapy. The problem with the targeted therapies is the development of other mutations or other ways that the cancer cell figures out how to get around the mutation. So in this diagram, you see the pathway that's sending the signal to the nucleus to grow. The BRAF mutated molecule is receiving the drug. However, there are additional other signals that the tumor cell turns on in order to get around what's happening with the drug, and then the disease starts to grow again. So one of the things that has been developed is that instead of treating patients with one drug with targeted therapy, we're treating patients with 2 drugs. And this is the one time where combination therapy actually reduces the side effects. When patients receive targeted therapy with a monotherapy against the BRAF gene, normal cells actually upregulate this pathway, and that can cause different kinds of problems like activated melanocytes and other kind of skin cells. You can increase the risk of rash. You increase the risk of certain kinds of skin cancers to develop, not melanoma, but other kinds of skin cancers. But if you add a second drug that inhibits a downstream element, what's called a MEK inhibitor, you can reduce the risk of some of these mechanisms of resistance to occur, and patients actually have fewer side effects. There have been studies that have looked at the combination of BRAF and MEK inhibitors, and we actually have shown that patients live longer when they get the combination treatment. And in all of these multiple studies, it looks like the patients who get the combination treatments do better than the single agent BRAF inhibitors. But still, as you can see here, as a total population, it looks like patients are ultimately succumbing to the disease, although these early studies, it looks like there might be a population of patients who are continuing to do well and the curve flattens out. This has been of real interest to us because our goals have really shifted from adding a couple of months or weeks of life to actually focusing on what happens with the patients at the end of the curve, where we're trying to increase the number of people who die from something else, not die from metastatic cancer. And in recent studies in the last year or so, we're finding that patients who have low volume disease, who go on to receive the combination treatments, can have improvement of survival, and it looks like there's a flattening out of the curve. So patients who have LDH is a blood test that we look at that's a risk factor for bad disease. So if your LDH is normal and you have disease in less than 3 organs, there's a population of patients that do really well. The majority of patients are still alive and are not having evidence of progression of the disease. So even though I first said that it was very disappointing with targeted therapy that we could get a certain population of people to do really well, but then then it wouldn't last very long, it looks like there's a subpopulation of people who go on to targeted therapies and they do really well with the pills. If we just continue the patients on the pills and they don't relapse or die from their cancer. So nowadays, there are some patients who go on targeted therapy with the goal of long-term disease control. Now, immunotherapy is also an area that has shown a lot of progress around the same time as targeted therapy came out. In fact, Yervoy, the first immunotherapy that has significant improvement in survival for patients with melanoma, that was approved a few months before the first BRAF inhibitor, vemurafenib, was approved. And what the immune therapies are aimed at doing is to help to induce responses and anti-cancer effects that target the patient's cancer. So the way to understand what immune therapy is that we're not really treating the patient's cancer, we're treating the patient's immune system. And the immune system is really good at recognizing foreign elements and like viruses and other things to eliminate invaders. Well, cancer looks a lot like normal tissue. However, there are a few differences, and these differences are called tumor antigens. The immune system takes up these tumor antigens from the tumor, usually an antigen-presenting cell or a thing called a dendritic cell, takes up these antigens, travels to lymph nodes, and then in the lymph nodes, and it can go anywhere. If you've had lymph node surgery, these treatments still work because they travel to other lymph nodes. The dendritic cell travels to lymph nodes where it induces a T cell response. The T cells then can traffic back to the tumor and induce an anti-cancer effect. The problem that we have with this immune response is that there are many ways that the tumor cell has figured out to evade the immune response. So in general, one example is that the T cell here represented here is able to recognize a tumor cell based on these antigens, but there are additional interactions between the tumor cell and the T cell, which basically tell the T cell, be quiet, move on, don't, it's kind of like in Star Wars where Obi-Wan Kenobi says, you're not wanted here, just move on or something. It's kind of what the tumor is doing to the T cell. But what we've been doing is we've been uncloaking this response by giving antibodies that bind this interaction, which then allows the T cell to actually see the tumor cell and kill it. The first treatment, Yervoy or ipilimumab, back about 10 years ago in a randomized study looking at a vaccine that turned out to be ineffective compared to Yervoy, showed a significant overall survival benefit. There was not really, there was a little bit of shrinkage of patients' tumors. About 10% of patients would have shrinkage. What's called progression-free survival, the amount of time between coming on to study and then your tumor starting to grow again, it really wasn't different between the two arms. But there's a group of patients receiving Yervoy who lived longer and seemed to benefit from the treatment. And in additional studies where more and more patients were treated with Yervoy, it looks like we have a significant improvement, around 22% with Yervoy, where patients don't die of their disease. Now, you might say 22%, that's not great, but that was the first time ever that long-term benefit was identified for patients with metastatic melanoma. And these curves usually would when you have metastatic melanoma in the old days, patients at 3, 4, 5 years, you would have about 10% of patients alive. So the way to understand this is that even though Yervoy has a very low response rate, the patients who actually do benefit have significant benefit where they don't succumb to the disease. It looks as though it's a very highly successful therapy in a subpopulation of patients. And we also think that these treatments also affect the way the body recognizes the patient's cancer, so that many of us think that patients who ultimately do progress after receiving Yervoy, where the disease grows again, the dynamics of that cancer behavior is different, that cancer doesn't grow quite as fast, and that patients are living longer also because of that effect. Now, the next set of drugs, the anti-PD-1 drugs, there are two drugs that have been approved in Canada, nivolumab and pembrolizumab. That's Opdivo on the left and Keytruda on the right. Both of these drugs, compared to chemotherapy, have shown significant improvement in overall survival. And in comparing patients who receive Keytruda or pembrolizumab compared to Yervoy or ipilimumab, there's improvement in overall survival. So now when a patient comes to see us in clinic, if we're going to give standard of care therapy, we would typically give an anti-PD-1 drug. Pembrolizumab is currently fully funded in Ontario, so that's the drug we would prefer, because patients live longer in comparison to ipilimumab. Now, so one of the questions about, when you look at the total response rate for the anti-PD-1 drugs, about 30 to 40% of patients will have shrinkage of their tumors, and maybe about 5 to 10% of those patients will have complete responses where the disease completely disappears. And the question that we all have is, how durable are those responses? There was recently a presentation at ASCO this last year where they looked at 95 patients, that's 15% of patients, in a combination of studies where they looked at what what happened to patients who received or had a complete response. So of these, most patients remained in complete response. Only 10% of those patients had disease progression. And some patients were maintained, continued on pembrolizumab. Some patients, about 20%, had to be taken off due to adverse events such as diarrhea or skin rashes or other issues, liver problems. And then another group of patients were stopped because it just got so boring coming in every 3 weeks for your infusion, or because of fear of side effects. And we looked at what happened to these patients who were discontinued. And it looks like even though patients don't continue on these therapies, most of the patients continue to be doing well without any evidence of progression. Most of these patients had a response within the first 3 months of therapy, not all of them. And response means, it's a technical term where we look at the CT scan, we calculate the measurements, and if you have to meet a certain amount of shrinkage of the tumor in order to have what's called a response. If those patients achieved a response, or the patients who had a complete response usually had shrinkage within that first CT scan that's done at week 12. But the interesting thing is that a lot of these patients didn't have a complete response for many, many months. So most patients, or the average patient, had a complete response at 13 months. And some of these complete responses occurred more than 2 years out on therapy. So the way to understand this is that a lot of times the immune system will induce a response, and sometimes you can see a very quick response and the tumor shrinks. But sometimes there's like a spot on the scan that the doctor says, well, I can't call this a complete response because there's still a shadow on the scan. And there have been examples where we have done a biopsy and then we find out that there are a few tumor cells left over. They're just being attacked by the immune system. And other times we've done biopsies and we find that there's just inflammatory cells. So, but not everybody can have biopsies or would want to have a biopsy when they're doing well. But eventually these lesions can shrink. The one thing to understand about pembrolizumab and the other anti-PD-1 drugs is that if you look at the total population, when you give these drugs and you have a response, not a complete response, but a response, about a third of patients will eventually develop resistance and the disease will come back again, and then we have to look at other treatments for those patients. But if you have a complete response, it looks like those patients do particularly well, and it's rare that they'll have the disease come back. Now, another treatment combination that isn't very easily displayed here on this curve is ipilimumab plus nivolumab. So that's an anti-PD-1 drug and ipilimumab, the Yervoy drug that I talked about at the beginning of the immunotherapy treatment discussion. So this combination therapy was just approved by Health Canada a couple of months ago. It's not yet approved for coverage by any of the provinces. It's going through a committee called PCODER, which is occurring now. The submission happened a couple of months ago, and now the committees are looking at the data. But we don't have overall survival data for ipilimumab plus nivolumab, but we do have what's called progression-free survival. So this is where you don't have to die to move down the curve, you just have to have the disease grow back, or to have evidence of the disease growing. And when you give a combination of ipilimumab plus nivolumab, you have significant improvement of this thing called progression-free survival over nivolumab, and much better than ipilimumab alone. And excuse me, this improvement is very promising for us because it looks like we're getting to where we have almost 50% of patients have the disease melt away and not come back. The response rate is very high. There are more complete responses with ipilimumab plus nivolumab. It's very promising. However, we don't have overall survival. The other thing to understand that these curves are generated from patients who receive no other therapy. Bristol Myers Squibb, which is the maker of these drugs, has focused on first-line treatment with ipilimumab plus nivolumab. We don't have a lot of data about this combination in patients who've received other therapies and then receive IPI plus nivolumab. The problem with the combination is it's pretty toxic. About more than 50% of patients will have some sort of adverse event. The sorts of things that can occur are pneumonitis, inflammation of the lung, diarrhea. You can develop problems with the liver. You can develop rashes. And occasionally these toxicities can be life-threatening. There was recently a New York Times article about cardiomyositis, a complication where the immune system attacks the heart. So these toxicities with ipilimumab plus nivolumab are a major issue. We're waiting to see whether the survival benefit is going to be worth the risk of toxicity. The anti-PD-1 drugs, however, have a much lower rate of adverse events, and it's actually lower than Yervoy, which has an adverse event that's in between IPI plus nivolumab and nivolumab alone. Now, so basically where we are currently, as we push the immune system and look at combinations, we're seeing side effects that may be too many side effects. But if it's worth the side effects because people are living longer, then we'll certainly use the medications. But the way to understand what's happening right now in development of these drugs is that we're weighing the benefit and the toxicity of drug combinations. And there are a lot of new drug combinations being investigated. If you look at this diagram, you see a T cell that has multiple different activating receptors that immunologists have identified and multiple types of inhibitory receptors. And we've only studied in clinical trials in terms of approval 2 of these receptors. All these other receptors that are represented here are in various stages of investigation, either in phase 1 trials or in additional immunotherapy trials. Also, there are studies that are combining T-cell therapy with targeted therapy. Anti-PD-1s are being combined with the targeted drugs in a series of trials that multiple companies are conducting. There are studies looking at combinations with vaccines and radiation, and then also T-cell therapy. So what's involved with T-cell therapy is patients will have their blood removed either through a blood draw or from a procedure called apheresis, kind of like giving platelets, where the white cells are removed and then the patient's T cells are engineered to have a new T cell receptor injected into the T cell. And then the cells are grown to large numbers and infused as a therapy. We have a study that's looking at one type of T cell therapy. You have to have a certain kind of HLA type, and your tumor also has to have the expression of the target. We're also doing work where we take tumor-infiltrating lymphocytes. That's where you take a tumor, try to grow up the T cells, and then infuse the T cells as a treatment. These are areas of research that are ongoing, and we're looking at combining these therapies with immune therapies to see whether we can improve the response rate. And here's an example of a patient who got T-cell therapy and had their tumor respond, and you can see long-term responses. So in summary, we're seeing lots of great responses to targeted therapy. However, even though we have great response rates, many patients do benefit from the drugs. Long-term control can be an issue except for some patients. The immune therapies are showing durable responses. Combinations are very promising. However, we really do need the overall survival data and in order to deal with the side effects. So in terms of the future, there are lots of new immune modulators for the patients who need additional therapy. We are finding that sometimes it's difficult to get patients onto trials if they've had lots of side effects from immune therapies, although I am seeing some of the later phase trials are getting rid of some of these exclusions. If you can understand, you might sort of wonder, why are these entry criteria the way they are? If a drug and a new combination has only been studied in a couple of patients in the world, or never, maybe you're the first patient in the world to get a certain combination, they want to try to exclude someone who's received a therapy in the recent months that might make a new side effect occur more likely. So many of the early phase studies require that you have a pretty good clean slate. But then as the drug gets more highly developed and we understand what the side effects are, the trials are a little bit more forgiving in terms of being able to put people onto studies. But it's a very exciting time to be working in this area. It's not an exciting time to have melanoma, of course, but it's certainly much better to have this challenging disease now, because there's so much more hope and encouraging results and the chance of having long-term benefit compared to 10, 20 years ago. So thanks very much, and I'll be happy to chat with you guys after.